We had the 6th World Symposium on Pulmonary Hypertension in early 2018, and one important task force had to do with chronic thromboembolic pulmonary hypertension. So the subject of today's conversation is, are the new consensus guidelines, or in these new consensus statements from the World Symposium, have there been any recommendations regarding CTEPH? And I think this is a really important topic, and let's review a little bit about what chronic thromboembolic pulmonary hypertension is and how that's differentiated from chronic thromboembolic disease. So essentially, chronic thromboembolic pulmonary hypertension requires the presence of pulmonary hypertension, but chronic thromboembolic disease means that the patient has persistent thromboembolic disease, often from an acute PE, but they don't really have pulmonary hypertension yet. However, both of these instances can cause exertional dyspnea for patients that can be quite limiting. The right heart cath is really the important thing that differentiates from the presence of pulmonary hypertension in CTEPH versus the absence of pulmonary hypertension in chronic thromboembolic disease. Sometimes we learn a little bit about the impact of the chronic thromboembolic disease at the time of cath and when we exercise the patient and their PQ slope is greater than 3 millimeters of mercury per liter per minute. So the pressure flow change really goes up. These patients can't tolerate the increase in flow. Their pressure goes up. The VQ scan really they have persistent defects, and this occurs in both groups. And both groups have typical findings of CTEPH on pulmonary angiography. Exercise can also help us learn about the symptoms in patients with chronic thromboembolic disease. Cardiopulmonary exercise testing may be important to exclude ventilatory limitations due to deconditioning. Sometimes they become dyspneic because of dead space ventilation. And it's important to look for other etiologies of dyspnea on the echocardiogram. Maybe they still have defects and they don't have evidence of pulmonary hypertension, but they have something else wrong with their left ventricle or valves. And so that might be the reason for their symptoms rather than the chronic thromboembolic disease. So that's really important to sort out. And it's also important to acknowledge that we don't call these disorders chronic until the patients have been anticoagulated for at least 3 months. So we're assuming that these patients have had that course of anticoagulation before we give them that diagnosis. Well, this task force, Task Force 11 on CTEPH, really did a wonderful job summarizing an area for which there have been a number of major advances since the last World Symposium. These advances have been in treatment and they've also been in imaging. And the conclusions from this task force really reflect the best practice at the current time. This was a great example of the multidisciplinary approach to this very complex disease. This task force included cardiologists, pulmonologists, cardiac surgeons, imagers, and many people are very important in the diagnosis and management of patients with chronic thromboembolic disease. And so they've really tried to up the ante on the evidence base of their recommendations, although acknowledge that we don't have great evidence for some of the data, some of the recommendations, and we certainly don't have comparable treatment efficacy amongst some of the options. So here is the algorithm that they came up with in terms of the management of a CTEPH patient. I think one of the highlights is that a CTEPH diagnosis requires a treatment assessment by an expert team, which is a multidisciplinary team. It's important to have the PEA surgeon involved, a PH expert involved, be it a cardiologist or pulmonologist, a BPA interventionalist involved, again, be it a cardiologist or maybe an interventional radiologist. And the radiology team is so critical. Sometimes there's also a hematologist involved. So it's really a multidisciplinary approach, and those folks need to get together and assess the patients. I mean, we have conferences of our multidisciplinary team that we talk about the patients and we go through the imaging and we make choices about what is the best approach to treatment. Really, the first step in the algorithm is, once you have all the data, the imaging and the like, is determine whether or not the patient is operable. If the patient has surgically accessible disease, really a pulmonary endarterectomy is the treatment of choice. If the patient is not operable based on their anatomy of the pulmonary vasculature, then we have other options: targeted medical therapy with or without BPA. And then it's always important to remember that no matter which of those options is chosen, some patients will have persistent or recurrent symptomatic pulmonary hypertension. So it's very remarkable, the advances we've made in chronic thromboembolic disease. A lot of data on balloon pulmonary angioplasty since the last World Symposium, and that was discussed in great detail. I think the things to highlight most about chronic thromboembolic disease are the multidisciplinary approach. It's really critical that all those groups work together, and to remember that if a patient has surgically accessible disease, that is really the treatment of choice. That's really critical to give the patient the best long-term outcome, and that's the standard of care in the US for sure. So I've enjoyed reviewing this data from Task Force 11, chronic thromboembolic pulmonary hypertension, with you. Thank you for joining me.